So I choose actually to talk to you, since we are a community of psoriasis experts, to talk to you how we work in Ghent and the efforts we have paid to improve the management of our psoriasis clinics. And what I really would like is that we have a lively discussion on what I am. Can I have the next slide? Yeah, so, yeah, sorry, slide before. So in Ghent, so I work in a big hospital. I work in the second biggest hospital, the University Hospital of Belgium. And in the Department of Dermatology, of course, we see all kinds of patients, all kinds of interventions that we do there, 31 consultations a year. And the first thing I decided whenever the hospital gave us the chance to do that is to take away our psoriasis consultation to a remote peripheral building, because the hospital saw that many patients are anxious to find parking, to find a way to the right spot in a very complex environment. So that's where we do on the right-hand side now 2 half days a week of psoriasis clinic, which we call Soplus. So we see about 1,600, or we have contacts with 1,600 consultations a year. We also published the way we work a few years ago, but we have been working in Soplus since 2012. Next slide. A big change, so what Soplus is about, I was really intrigued by the major breakthrough we have had in psoriasis insights, not only pathogenesis, but also on the comorbidities, on the quality of life, on the burden of disease, on what is a severe patient, and how we should surround these patients. And we believe that working in the very classical way, the blue way, the classical way in healthcare, that a patient goes through a very siloed journey, that he has to find his way to the right specialist. So in Soplus, we say the patient more and more should be in the lead, and a team is welcoming him or her face-to-face or virtual. And actually, there is a continuity of contact between the team and the patient. So we not only we see patients in the clinic, but continuously we have a form of contact with our patients. So the patient is seen as an active partner. He has some homework to do for us every now and then. And we also have made sure that our team is multidisciplinary. So this is Soplus. You can have the next slide. So rather than delivering patients a very serial room after another, we made patients the owner of their own rooms in the care path, and instead we circulate the providers around the patient. This is a statement coming from another publication, but which resonates very well with how we work. Yes, next slide. And you know, at a certain point in 2012, when we started working like this, and the months thereafter, my colleague said, how do you know, with all the resources you use, you use 2 nurses, 1 doctor, you have contact in between, you have an administrative person which takes a lot of the questions. How do you know that it's worthwhile to invest so much in your patients resource-wise? And that's where I came to the concept of value-based healthcare, a concept of Michael Porter and Elizabeth Theisberg, which you see below on the right side, which actually puts value for the patient very central. And you can only deliver value, they say, if you cover the full cycle of care for your patients in all its aspects. So also for psoriasis in terms of tackling the comorbidities, looking at the quality of life. So you need to organize yourself in an integrated practice unit, as they call it. And to show that you bring value, you need to start measuring outcomes. And of course, you also measure the cost, because it's always a balance between having the best outcomes at a reasonable cost. But when you measure the costs, you can continuously improve yourself, because you have a kind of check if what you are investing in your patients is really worthwhile and leading to the best value. They go even further. Rather than getting a fee each time you see a patient, they say, why not look on a yearly basis and say, this is a bundled sum you get for your patients to follow them up in a year's time. And it's up to you to decide if you don't see them or see them 5 times. So you get a fee or a bundled payment for this. Good, next slide. And this equation is very important in value-based healthcare. Value is equaling the outcomes you receive when doing your care over the cost it takes to achieve those outcomes. And let's focus on the outcomes first. You can click and then go to the next slide. Yes, next. So let's see where in literature, this is what we did the last years, and these are new data and confidential data not published yet. Let's see where the patient voice has helped to make care more appropriate. Let's look in literature where people have been looking to the field of outcomes, which outcomes are important, but we only took those studies where also the patient had a voice. So we call it Exploring Value in Psoriasis. We did a systematic review on patient relevant outcomes. So what is relevant to check? And also the patient was sitting in the teams that decided that. It's interesting what comes out. You can click further. What comes out is many studies. The world of outcomes has, of course, boomed because many clinical trials have been performed which needed those outcomes and the instruments to measure them. And in the end, we had a lot of study, but we came up with 23 patient-relevant outcomes, which we grouped into 4 core areas. And if you would start measuring those outcomes, in your clinical care path, this might aid the transition to a value-based healthcare approach because you measure value. Next slide. So these are the outcomes that you see here, the 23 ones. Noteworthy is that, of course, physical outcomes like complete clearance, almost complete clearance, treatment efficacy were reported very often in literature. And let's look at, for instance, emotional well-being. This is much less reported. Having the feeling I control my disease is also less reported on. But nevertheless, we took all these, the 23, and next slide, we presented those to our own patients. So first we did a modified nominal group technique with 8 patients. We discussed an evening discussion. What do you think about these outcomes? Are they important? And they say our Ghent patients ranked them in order of importance. Next slide. And well, actually, the percentages are a bit different than in literature. Top is symptom control. So patient finds it's very important to have symptom control, of course, treatment efficacy. But for instance, having confidence in the care you receive and having the feeling I control my disease were ranked very highly. So this is really a perception from the patient side, which was ranked very high and didn't come out of the systematic review. On the other hand, things that we work on a lot, like trying to raise the awareness of comorbidities, was ranked very low, which shows that our patients are not really bothered with the comorbidities, although from a medical point of view, we think this is very important, and it is very important. So bringing value is taking into account what the patient finds very important, but not neglecting what you as a medical doctor also find important on the long run for a patient. Also, how much the care costs didn't matter to our patients, because Belgium is, of course, a very well taken care of social health, has a very good social healthcare system, and the patients hardly have to pay anything for their care. This might be very different in other countries. Okay, so we have a kind of set of outcomes here. Next slide. That we want to work around, and we want to get the best results in those outcomes. So how did we get organized? Next slide. So we organized Soplus, yeah, next slide, in our integrated practice unit. And actually, what you might also be doing, and I'm glad to hear about that, is we have a very structured approach in our consultation. You see all the blocks that we really click and tackle in order to get the best information around the patient that is sitting in front of you. We call it our Soplus 2.0 because we have been updating it already. So a structured electronic health record collecting all of the data. Next slide. We also have, and this is new, a patient platform, a kind of protected area, a virtual area, where we can send, before consultation, questionnaires to the patient, but also little assignments like go to the GP to have a blood check for cholesterol, for instance. But it is also a system where the patient can book his consultation himself. We also give advice through this patient platform in between consultations. So whenever a patient is anxious about something, we give advice through this protected system. It's also a learning environment where we put educational videos, and you can click, because I have some examples. So we explain what psoriasis is. We explain about, you can click twice, about the comorbidities, about possible treatments, and also about how Soplus is an added value for them. Next. So this is again our building. So in this system, a patient comes in, there is some pre-information that we have because the patient filled out things at home. And each consultation, what we do is we check whether we are ambitious enough. So you see here a national consensus that we made with Belgian psoriasis expert. And we think it's important that each consultation you check whether the disease is under control, of course, whether the patient well-being is okay, whether the treatment is not too burdensome, and whether the comorbidities have been detected and referred for. I will not go into detail, you can read this publication, but whenever one of the outcomes in this treat to target environment is not taken care of, this is for us a trigger to add something to the treatment, to change something in the management. So it keeps us very awake, I would say, to get the best results in our patients. Next. We also have a predefined path to other specialists, because these are expected visits. So we have reserved spots in the other departments. For instance, with the rheumatologist, we can book every Tuesday, we can book consultations. It's open only for dermatology. We have a psychologist also with open slots only for dermatology, because these are expected visits. It always fills to the fullest, so it's foreseen and it's always full. We also have a back and forth communication with the GP to tackle, amongst others, the metabolic syndrome problems. Although the patient doesn't find this very important, but we think it's important. So this is taken into account. Next slide. So this is how we try to achieve the best outcomes through our organization. And I'm very curious how you get organized to achieve and to tackle the complexity of psoriasis to get the best value. Then, of course, there's the denominator of this equation, which is the costs. And you can click and even click one more. You might say, well, this must cost a lot, what this lady is doing with her team. So I don't know if my hospital would allow 2 nurses, 1 doctor, contact, which is not paid in between consultations, etc. Well, let's have a look how we deal with that. Okay, next. What an economist has been doing the last years, so we have a collaboration with a business school here in Ghent. They have started to apply the technique of time-driven activity-based costing. So what is the true cost of the way we are working? And really this comes down to measuring how many minutes each step of our care path takes. And you can see here an example of it. And it was calculated that only the dermatology part, so not even the referral departments, what we are doing costs on average 72 euros to get the value we expect to have. And what you also see here, left bottom, is that a doctor costs 5 times as much as the salary of a doctor is 5 times as much as the one of a nurse and the one of a secretary. So we have all reason to use the doctor as little as possible and to promote contact of the patients with the nurse. I will show you how we do that. Next. So we believe Soplus generates the best value, and we know it costs a lot, so we can only try to limit the cost because we don't want to change the way we are working, but we need to limit the costs in clever ways. And we also published on cost drivers in healthcare systems. You can see that below. Next slide. Okay. So first thing we said, would it be as good to work with only one nurse, because personnel costs a lot. And so the economist, Erin, she sat down and was calculating. But what happens when I only have one nurse is that I have to sometimes wait, and actually the waiting time in between 2 patients, because she was not ready yet, also costs a lot. Okay, I can do other things, but practically spoken, it would be better if I also see patients in that time. And actually it was economically much better to work with 2 nurses, so because my waiting time was going down. It's very interesting to do things like that. So we continue working with 2 nurses. That was one conclusion. Next slide. So this is how we work. We have 2 nurses. They work 15 minutes apart. So nurse 2 sees the first patient, and 15 minutes later, nurse 1 sees the second patient, which means that I get fueled, or the dermatologist gets fueled with patients every 15 minutes. So the nurse takes 30 minutes and I take 15 minutes. Okay, this is how we started, very basic. Yeah, you can click. But we said not all patients are the same. Why don't we try to be more efficient? You can click. If we make focus points, we all know you can click that we have new patients, but that we also have known patients, and it takes another form of attention and preparation maybe. So we started having slots only for new patients and only for known patients. And next, we also saw that there are patients, you can click twice actually, that only come to get a refill for their biologicals, and this really takes little time also with the nurse, and I could in the same time period see 3 or even 4 patients there. And there is also the possibility for a PSO on demand, so booked by the patient, because he has an alarm sign for something. So those consultations are also shorter because the patient is already very grateful that he can be seen by us. So by making more clever subdivisions of our appointment system, we could see 25% more patients with the same crew. So this is more efficacious or more efficient cost-wise. Then came in the time of the teleconsultations, was since the pandemic even we got a fee for that. So before that, we didn't get a fee. In Belgium, we get 17 euro for a teleconsultation. And you can click 1, 2, 3 times. So whenever I had a spare time moment, I booked a teleconsultation. I also booked a maybe a PSO on-demand physical consultation could become a teleconsultation with the same value for the patient. But what I would like to point out here is that if you look at teleconsultation doctor in the table, it sometimes takes a lot of time, and it's not really less costly to do a teleconsultation in our hands than seeing a patient live. So there I would prefer to keep on doing live consultations, or also look where maybe a teleconsultation can be done by a nurse with the same value for the patient. Okay, you can go to the next slide. So this is an optimization system. I told you that we also have an administrative person reading the messages from the patients in between. And it's amazing how much administrative burden the biologicals bring along. There's a lot of paperwork, at least in Belgium, prescriptions that have run out of date, etc. But also she receives a lot of calls and messages to get an appointment. So we calculated if we could move to the fact that the patients go for an online scheduling system. So like you do in a restaurant, you book your own appointment. This could already save us 16,000 euros in personnel cost per year. Okay, next. So we integrated, or we try to integrate this now to go to an online booking system, very well explaining what the different consultations types are. With regard to messages about reimbursement forms for biologicals, I have no solution yet. In the end, I have to do the signing, etc. Should I make it a teleconsultation or what? I have no, or could it be done by a nurse? But then the nurse doesn't have the authority to prescribe. So this is also a point where optimization is possible. Next slide. Good. Actually, what I have been showing, I have come to the end, is something I would like to discuss with you. So what I have been showing is that we have been structuring our patient files to grasp all aspects of the psoriasis patient. We do this since 2012, so we have a full image of the patient, and actually it's the nurse who grasps all this information. And when the patients come to me, the last 15 minutes, I already have a kind of profile of my patient, and I immediately start the clinical examination, and I measure the PASI scores myself. This was a question in the chat. And I start the management for my patient. So we have predefined or pre-reserved referral paths to other specialists that we need anyway. If possible, we let the nurses help. We try to motivate our patients to help add information and take up active responsibility through the patient platform. And we know we are more costly, but we hope to show in a trial that will start soon. We will start measuring our 21 outcomes. We hope that we can show that the secondary savings we have actually are much higher than the higher costs that we are taking. And this concept is value-based healthcare, could easily be copy-pasted to atopic dermatitis, hidradenitis, autoimmune, blistering diseases, any chronic immune disease of the skin that you can imagine. And last slide, you can click twice. Yeah, you can click. I want to thank my team, these young people I have recruited like 4 or 5 years ago. These are the 3 left ones are my 3 PhD students. Right-hand side are the more senior postdocs in the team that are really passionate about value-based healthcare and also biologicals. And we have a very nice collaboration with Vlerick Business School in Belgium. We need the economists for this. And partially, we also get funding next to government funding. We get also Janssen and Novartis funding. Thank you very much.